Hello everybody, I am Dr. Anshuman Agarwal and I am a senior consultant urologist with the Fortis Group of Hospitals, New Delhi. I have been doing holmium laser enucleation of the prostate since the year 2002 and have done approximately 1500 cases by this time. Now we have started the cystoscopy and this this is being done using a 20 French cystoscope sheath and a 30-degree telescope. You can appreciate the merging lateral lobes of the prostate. The median lobe is not very much enlarged and there are some trabeculations inside. That's the left ureteric orifice and that is the right ureteric orifice. So initial cystoscopic assessment is very much essential because you need to plan the first incision. You need to plan whether you need to do a 2-lobe technique or a 3-lobe technique. Once you have gained experience, my suggestion is to start with the 3-lobe technique, and once you've gained experience you can proceed to 3-lobe technique, but this video shows a 2-lobe technique. So you can see that the the lateral lobes are occluding and they are causing obstruction. Now this laser fiber has been introduced through the laser bridge, and I have planned to start by making a single cut in the midline at the 6 o'clock position. So that is where I intend to start, by making a cut at the 6 o'clock position. If the median lobe is very large, in that case you can make cut at 5 and 7 o'clock position, do away with the median lobe and then proceed with the lateral lobe enucleation. So the initial cut extends from the bladder neck up to the veromontanum, and at the level of the bladder neck we have to make sure that we have to lower it so that we can see the trigone well, but not go any further deep, as that can result into perforation and a subtrigonal perforation. Now once having completed the first incision, I normally disconnect at the level of the veromontanum first. At this point you can encounter some troublesome bleeding because the flow of the irrigation fluid is not very good at this point. Now you are seeing that I am extending at the same horizontal level from my initial cut in the midline, and I have to extend. Now I am deepening the cut at the level of the bladder neck. I am further deepening the cut. So this is a procedure where there is no fixed thing, and as and when you have to innovate according to the anatomy of the prostate. Now once having fixed the distal landmark, I am deepening the cut and gradually I will take it laterally, that is beneath the. Now I have seen the ureteric orifice. It is very important to make sure about the position of the ureteric orifice at that time, because you can injure it if you inadvertently fire the laser on the ureteric orifice. Now I am moving my laser fiber laterally, and this is the advantage of using the current laser working element, that you have a freedom of movement. Of once you are holding the working element, you can move it the way you move your TUR working element and with the rotatable inner sheath. So you can see that the laser fiber is working in the right plane, and once the right plane is achieved, the prostate starts lifting up from the capsule. You may encounter few small nodules, as you can see in this case, because we all know that prostate is not a spherical structure, it is a multinodular structure, and once you are enucleating there may be few nodules that separate from the main gland, but that does not matter, as you can see that this nodule can be very well taken care of. At this point, after having reached up to 3 o'clock position, we start our dissection from the midline, and we have to turn our scope upside down so that you can reach up to the 12 o'clock position. And the 12 o'clock cut, once you are making that, you have to be careful that you don't extend distally into the sphincter, and as well you have to make sure that you don't go beyond the capsule. So once you start, I will soon show you where the capsular fibers are, but once you start making the central cut in the 12 o'clock position at the midline, you have to keep in mind these things, and the cut should be straight and there should not be deviating lines, otherwise you land up between the prostatic tissue and not in the right plane. And you can see that once I have reached these, you can see the circular fibers of the capsule, and once I have reached the capsule, I start moving laterally. And if you imagine, if you are doing a Freyr's prostatectomy, there also, after breaking the anterior commissure, you move your finger sideways and working between the adenoma and the capsule. So this is exactly what is being done here, that the capsule is laterally and the adenoma is medially, and the laser fiber is working between the capsule and the adenoma, thus separating the adenoma from the capsule. Now we come again distally and the purpose of this part of the dissection is to separate the adenoma from the sphincteric region and avoid, and you have seen that there was a small tag of mucosa that was attached anteriorly which has been separated, and now I am working all around the adenoma to separate it from the sphincteric region. You can see the circular motion of the laser fiber, where you can see that from the 12 o'clock I am coming to the 9 o'clock position. Slowly I am slowly detaching all the fibers of the capsule which are adherent to the which are attached rather to the apex of the prostate, and this is at the 3 o'clock position. I am trying to move circularly like this and going all around the prostate. My midline landmark is clear, my floor landmark is clear, so all I have to do is, just as I move my finger in open prostatectomy, I have to move the laser fiber all around the prostate so that I can separate the adenoma from the capsule. This is again close to 5 o'clock position, and you can see that the midline landmark can be seen very carefully here. If you see, the middle groove is seen, and from the midline groove I am extending laterally. So once I am doing this maneuver, I can keep my scope horizontal and at times move it like this, whichever way is convenient to you. And once you are going all around the prostate, so you can keep on inverting your scope and go all around the prostate. So this way you can encircle the prostate and detach it from the capsule. You can notice in this part of the video that some nodules of the prostate, as I told you earlier, that this is a nodular hyperplasia, so some nodules of the prostate can separate, but that is not a problem because you can enucleate these nodules separately in case you have left them. But it is important to recognize their presence and not leave them there, as later on they can get detached from the capsule itself and cause urinary retention. So you can see the laser fiber is nicely moving and the capsule has been defined, and the laser fiber is moving in a circular fashion all around the prostate adenoma, and at all times I have the laser fiber tip in my side and the capsule in my side, and this is sort of a retrograde enucleation because we are going from the apex towards the bladder neck now. That is the 1 o'clock position, and from 1 o'clock position we are encircling towards the 3 o'clock position. Again we reach around 1 o'clock position and we are bringing the laser fiber down in a circular manner, following the natural curve of the prostate and the capsule. If the fiber goes out of sight at this point in time, then you can enter the capsule. But since in holmium laser the depth of penetration is very small, and you can, if you see the tip of the fiber, in that case you can see where your fiber is firing, and then the chances of capsular perforation are practically nil. You can see I have reached up to the bladder neck at the level of 5 o'clock position, and from the bladder neck I am bringing my laser fiber, moving it circularly all around and taking it all the way up to 1 o'clock position. So that is the circular sweeping motion by which you can disconnect the adenoma from the capsule. There are some fibers of the prostatic tissue which are adherent to the bladder neck, and there you need to divide them, and the prostatic lobe is being lifted up from the capsule. Only a small connection is what it remains now. Now as you reach the bladder neck, we all know that the bladder neck is more fibrous than the distal parts. So it takes slightly longer, so you have to persist with your laser fibers there for few more seconds, and then you are able to cut the fibrous tissue nicely. Now you can see the last of the attachments of the prostate with the bladder neck have been divided, and the prostatic lobe has been pushed into the urinary bladder. You can see from the apex that there is no apical tissue of the prostate that remains, and this is the beauty of this procedure, that you can remove practically all of the adenoma by enucleation. Now I have started working on the right hand side of the prostate lobe, and you can see that I usually enter into the plane from the level of the apex because the prostate is very bulky at this part, and it is easier to separate the adenoma from the capsule, and you can see how nicely the capsule is separating from the adenoma. and you simply have to point your laser in the direction close to the prostate, and the prostate keeps on lifting by the means of the water flow and also by the help of the beak of the scope. And it is important to lift the prostate by the beak of the scope, because it does, otherwise it will not give you any space for the fiber to work in. And now again the landmarks are the 12 o'clock incision and the 6 o'clock incision. So from the 6 o'clock incision we have to move laterally, go up, and from the 12 o'clock incision we have to move laterally and come down like this, so that both the incisions they meet in the midline, and then you separate the prostatic lobe into the bladder. At the same time you have to be careful of the sphincter, and it is always wise to separate the sphincter from the adenoma under vision. So you can see I have reached up to the bladder neck, and from the bladder neck I am moving laterally and lifting the adenoma from the capsule. It is very important to follow the circular fibers of the bladder neck and follow the natural curves, because if you don't follow the natural curves, then you will extend laterally and then you will perforate the. So it is important for you to realize the natural curve, and once you are following the natural curve, you will automatically start moving up like this and not go all the way horizontal like this. So you have to respect the natural curve of the prostate. So now you can see that I am moving from below up and moving gradually towards the 3 o'clock position, and the prostatic lobe has been lifted from the base and it is being lifted upwards, and you can see now that the prostatic lobe is detached, and I am moving towards the apical. Again I have turned my scope upside down, because this gives me a better position of the laser fiber, and that is the line of incision which I am showing with the laser fiber that I have to make to separate the adenoma. I am coming from above, because once you have done away with the one lobe of the prostate, it is easier to do the other lobe, because your landmarks are more clear. So I am giving the circular incision at the level of the apex of the prostate to detach the adenoma from the capsule, and this avoids my dissection extending into the sphincter and thus causing any incontinence in the post-operative period. This is starting from the 12 o'clock position, and I'm again, as we did for the opposite side, I am bringing the 12 o'clock incision laterally to extend it between the adenoma and the capsule. You can see some twigs of prostatic tissue, some fluffy prostatic tissue that is there, and which can be removed very simply by just shaving it off from the capsule. Now I am working from the base up. You can see how nicely the adenoma is lifting up from the capsule just by working in the proper plane. You can encounter few bleeders, and you can take care of the bleeders by keeping the laser fiber away from them and firing so as less energy reaches, which is more coagulative. You just saw that the connection of the prostate with the sphincter at around 11 o'clock position, which is being severed under vision. This is a bleeder. Again you can see it is being taken care of by defocusing of the laser beam and coagulating the bleeder. This is apical dissection. We are moving from below up in this case, and you can see you can come from above below or below up. It depends upon your understanding of the anatomy, and there is absolutely any scheme that fits to you, you can apply, but the bottom line is that you have to go all around the adenoma, and that motion has to be a circular motion. It cannot be anything less than a circular motion, and for any circular motion you have to achieve the proper depth, and that is the most important part of this procedure, to realize the proper depth. And once you are familiar with the depth of the prostate, then this becomes a very simple and easy procedure. And you can see that by recognizing the capsular fibers and keeping towards medial side of them, you can comfortably work between the adenoma. And in this case you have seen that I have come all the way from below up, rather than from coming from above and going from below. I have come all the way from above and gone all around the adenoma in a single sweeping motion. So this is some part of the 12 o'clock attachment which I am taking care of, and these are small bits of prosthetic tissue that remain, and they can be removed later on also. Even if I don't remove these small bits of prosthetic tissue, they can get sloughed off in due course of time. Again, I have come to the base of the prostate, to the floor of the prostate, and lifting it from below above and moving all around. Mind you, that is not a capsular perforation, that is probably a nodule of the prostate that is going deeper at that point, and you can see smooth mucosa beyond it. Now you can see it is very nicely seen that what remains of the prostatic attachment with the capsule, and you have to just divide them with the laser fiber, with the end on fiber under vision. You can see the bladder neck, and you can see the hollow, the black hollow inside the bladder. That means you have reached up to the proximal limit of the enucleation, and these are the very last fibers that you are separating from the bladder neck attachment of the prostate gland. You can see now I am coming from above below, but you will appreciate that always the motion is like a sweeping motion, like your finger is moving between the prostate and the capsule. You can see that I am dividing the attachments of the lobe with the level of, from the level of the bladder neck. This is coming from below above, and you will appreciate that both the lines from above as well as from below are meeting at one single point. So that helps in pedunculating the prostate, and then you can divide the peduncle in retrograde manner, and you can see the last bit of attachment that is being divided under vision, and the prostate lobe is being pushed inside the bladder. So this enucleation process, you can probably time it. It is close to 25 minutes, I think. That's the level of the external sphincter. It seems pretty preserved, and there is no sign of any apical tissue left in this case. And I'm moving my scope all around, and you can see capsular fibers. There are no major capsular perforations. That is the level of bladder neck. These are the floating lobes inside. It is also helpful at this point in time to visualize the ureteric orifices and ensure their safety. That's the left ureteric orifice there. That's the left ureteric orifice, and then gradually we can have a look at the right ureteric orifice also. Now I have inserted a 26 French straight nephroscope inside the urinary bladder. You can appreciate some trabeculations there. These are the floating lobes. As we told you initially that this is a two-lobe technique that we are following here, and the floating lobes you can appreciate. So this is not a continuous flow equipment that we are using at the moment, and with this also you can see that there is not much blood inside the bladder. So it's practically, I would not call it a bloodless procedure, but practically the blood loss in this procedure is minimal. And you saw also during the procedure that I did not take any special instruments or any special means to coagulate the bleeders. So the bleeder that are coming, they are getting coagulated by the laser itself. Now I have introduced the morcellator, and I have caught hold of one of the lobes and I am morcellating it. Now during morcellation you have to be careful that it should be done in the most capacious part of the urinary bladder, and once you engage a tissue, you should make sure that this is the prostatic tissue and not the bladder wall. You should move the morcellator handle left and right, and to see that that it is not the bladder wall, it is only the prostatic tissue. At all points and during the morcellation, you should make sure that the water inflow is fully open and that the water is flowing nicely. And you should have the suction on the morcellation morcellator. I keep it around 60% and the morcellator speed is to the full. And you can see that always I will keep the tip of the morcellator under vision, and in between I check, I give some time for the bladder to fill. Once there has been continuous morcellation for a minute or two, I leave it for some time and I give it some time for it to fill, and then again I start my morcellation. You can see that in this case there is good vision because the bleeding is not there, but in case you have encountered some bleeding during the procedure and the bladder is not clean, then you can also do one thing, that you can take your TUR set and you can cauterize one or two major bleeders that are there, and then once you achieve a better vision, you can do the morcellation then. That is rarely required. After good number of cases, after good experience, this will never be required, that you take a TUR scope and then you coagulate the bleeders. Sometimes when you are doing very large glands, then the surface of the prostate is continuously oozing because of a large area of dissection, which keeps the vision slightly dirty. In that case, you can empty the bladder again and again to flush out all the blood colored fluid inside the bladder and have a clear vision during morcellation. So clear vision during morcellation is imperative to avoid any injuries to the bladder. And as you can see, after a minute or two of morcellation, I always leave the paddle and I give some time for the bladder to refill and to reorient myself. Now, catching smaller pieces it becomes more tricky because they are running away by the flow of the fluid. So what you can do, you can pinch the fluid for a second, and once you've caught the piece in the morcellator, you can let go of the fluid and the fluid starts refilling, and then you are sure that the piece is not going to run away because it has been caught within the morcellator blade. During morcellation, another important point is that once you press the paddle half, then it starts the suction, and once you press full, then it starts morcellating. So the first press on the paddle, it engages the tissue, and then if you press subsequently harder, then it starts cutting. Now this is some blood that has settled inside the prostatic fossa, and you can wash this blood off because it can cause some catheter blockage, which is not desirable. After having morcellated the tissue, you should go inside the bladder again, and these are small polyps of the previous catheterization. These are catheter-induced cystitis. You should go again and check for residual tissue here and there. Small nodules may be floating, and you can appreciate the sphincter nicely at this point, and there is no residual tissue there. And it is important to check every part of the bladder because small bits of prostatic tissue can be floating here and there, and they can cause obstruction after removal of the catheter. And you can appreciate the clean fluid that is coming out. So friends, at the end of this procedure, I have inserted a 12 French 3-way catheter. The effluent I have shown it to you. It's pretty clear, and I have not put any traction. I have inflated the balloon of the Foley by 30 cc's of saline and started an irrigation. You can also avoid the irrigation, but it is always better to have some irrigation going on for the initial few hours. You can have it slow, because during the process of shifting of the patient, sometimes there may be jerks and the catheter may get pulled and there may be some bleeding. So it is good to have irrigation on for a few hours of the initial part of the holmium vessel enucleation of prostate. And the catheter normally can be removed after 24 hours of surgery. My practice is to remove around 36 to 48 hours of surgery. But in case you see that the patient does not have a decompensated situation, does not have a high residual urine, or does not have a chronic retention, you can remove the catheter in 24 hours time. But you should warn the patients of maybe some dysuria initially, and give analgesics and anti-inflammatory drugs, and a few drops of blood can also come after removal of the catheter once the patient passes urine. So so friends, I hope you like the procedure, and I would be happy to answer any of the questions that come to your mind.